Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. This is part of the Classic Clinical Presentation Series. And today, we're going to meet Ellie Clayton. Meet Ellie Clayton. Miss Clayton was brought in by EMS after she had a seizure at home. She is hypertensive and appears altered. The nurse comes in and finds her to be speaking in an unintelligible way. She had heard that the patient had a seizure, but now she starts to think that perhaps she has more than that. In fact, she has pretty significant altered mental status. She tests her blood sugar and finds it to be 120 and runs to get the doctor. There are a few reversible causes of altered mental status. I like to remember them as don't forget the don'ts. The D is for dextrose, which treats hypoglycemia. The O is for oxygen. The N is for naloxone or Narcan for opiate overdose. T is for thiamine deficiency, and S is for shock. After a seizure, it is not uncommon for the patient to suffer altered mental status and decreased alertness. Initially, they are typically unresponsive with sonorous respirations. But the post-ictal period is typically brief, usually a few minutes. During that time, the patient is progressively improving, and that should be obvious. The doctor comes in and agrees that she is much more altered than would be expected this long after a seizure. Her oxygen saturation is 94%. She has no clinical evidence of opiate overdose. Her vital signs do not suggest shock. Her physical examination is significant for decreased arousal, and she is mumbling incoherently. The doctor knows that when the brain is not working, the epiglottis might not be working either. So she checks her gag reflex and finds it to be intact. It was difficult to get Ellie to cooperate with a neurologic exam, but she did not appear to have any focal neurologic deficits. She had no evidence of trauma. Her laboratory studies were sent, and the doctor ordered a CT and sent her over. When she was in CT, the tech called and said, Ellie Clayton has a big brain bleed. The doctor checks the CT and found the patient had a large hemorrhage in the basal ganglion. The doctor knows that the basal ganglion is the most common location for a hypertensive intracranial hemorrhage. The patient is brought back to the emergency department and the doctor orders nicardipine. The nurse is putting up the nicardipine drip. Nicardipine is a fast-acting and easily titratable calcium channel blocker that will bring down the blood pressure. This is important because you need to bring the blood pressure down to reduce further risk of hemorrhage. It is also very important not to overshoot and drop the blood pressure too much because the injured brain tissue is vulnerable and is very dependent on cerebral perfusion pressure. Cerebral vascular autoregulation provides a constant cerebral perfusion pressure over a wide range of mean arterial pressures. But this assumes a constant intracranial pressure. The equation for cerebral perfusion pressure is the mean arterial pressure minus the intracranial pressure, which under normal circumstances is relatively constant. If intracranial pressure is elevated, it will reduce the amount of blood that can flow into the brain. The brain needs a constant supply of blood that brings it glucose and oxygen that it needs desperately. Here's something that you may not think of. The brain box, or skull, only has room for three things in fixed proportions. That's the brain, which accounts for about 1,300 cc's, the blood, which is about 130 cc's, and the cerebral spinal fluid, which also is about 130 cc's. If you have proportional changes, it can be very problematic. If one volume increases, another has to decrease. This is called the Monroe-Kelly doctrine. The upper graph shows the normal proportions. In our patient, the proportion of blood within the skull has increased dramatically. Therefore, the brain and the cerebral spinal fluid are compromised, and the intracranial pressure is increased. As you can see, there is an increased blood volume within the skull, causing the brain to shift to the other side. The right ventricle is also smashed and shifted to the left. The doctor is making arrangements for admission to the ICU. She is considering which medication to use to prevent another seizure, which could cause more bleeding or lead to cerebral anoxia and make things much worse. When the patient's mother comes in, the doctor tells her that her daughter has had an intracranial hemorrhage, likely related to severe hypertension, and that she is doing everything she can to make sure that she has the best possible outcome. She asks the mother what happened at home. The mother said that the patient does not have high blood pressure. She did have mild preeclampsia with the twins, but she had no other problems during the pregnancy. Since the delivery 1 week ago, she started to have strange swelling in her legs, and then she started to complain of headaches. Over time, they became so severe that she was hardly able to engage with the babies. Today, she had such a bad headache that she couldn't even get out of bed. Then later, she came stumbling out of her room, said something that didn't make any sense. She fell to the floor and started seizing. She had never had a seizure before, and the mother was terrified and called the ambulance. She wants to know if her daughter's going to be okay. The information you just gave me is very helpful, and I think it will help me to help her. This is a very serious situation, but I will do everything I can to make it better. The doctor orders magnesium, 6 grams IV. The nurse gives the magnesium. The neurosurgeon was called and he's looking at the head CT. And the patient is admitted to the ICU. What happened here? Well, the patient has postpartum eclampsia. Although unusual, postpartum eclampsia occurs about 14 to 33% of the time and can occur up to 6 weeks after delivery. What is eclampsia anyway? Eclampsia is the combination of hypertension followed by seizures in pregnancy. It is often preceded by blurred vision and headaches. It typically occurs in the second half of pregnancy. Of all the patients with preeclampsia, which is elevated blood pressure and proteinuria, only 3% go on to eclampsia. Eclampsia is life-threatening to the mother and the child. It most commonly occurs in very young mothers and much older mothers. You'll see it most often in the first pregnancy and with multiple gestations, like the twins that our patient had. Magnesium sulfate in high doses can prevent seizures and may improve blood pressure, but additional medications are often necessary to treat the blood pressure. And the magnesium does not treat an active seizure. In that case, you may have to give diazepam to stop it. Magnesium is preventative. Eclampsia does not actually require severe hypertension. Blood pressures greater than 140/90 are considered very significant in the second half of pregnancy, when physiologic changes cause increased blood volume and vascular relaxation. Eclampsia is not commonly associated with intracranial hemorrhages. The hemorrhage was likely caused by a precipitous increase in blood pressure. In this case, the treatment is focused on managing the blood pressure. Surgical intervention is rarely necessary, but the neurosurgeon is typically involved in management. Now let's check on Ellie. Ellie is finally out of the ICU. She is better and finally able to see her twins. Thank you, doctor, for helping to give her a chance. Thank you so much for learning with me today. I really appreciate your engagement. Please like and subscribe to this YouTube channel. It really helps me, and you will be notified when there is new content. If you like it, please leave a review and keep studying.